I'm Mike Antoni, and for the past 30 years, I've been conducting research in behavioral medicine and health psychology, which is designed to identify the role of stress moderating factors, and stress management interventions in a wide variety of patients dealing with medical conditions ranging from HIV and AIDS to different cancers and other chronic medical conditions. I collaborated with Ted Millon over this period to create the MBMD and its various test reports, as well as conducting empirical research to evaluate its validity in different medical populations, including, for example, people with HIV who are on antiviral medications, heart disease and stroke patients on blood thinners, heart failure patients, prostate cancer patients, and most recently, patients participating in pain treatment programs and patients undergoing bariatric surgery. We recognize the need to adapt the MBMD for the use in specific populations who have specific challenges and for whom the clinician needs different information. Before I get started, I'd like to get a sense of your background in using the MBMD and specifically using it for pain patients. So please respond on the next two slides with your prior familiarity with the test. Thank you. The topics presented in this webinar will center on the use of psychosocial testing among patients dealing with chronic pain. We will present information on the development and utility of the MBMD in different pain populations and ways to assess patient characteristics in order to predict success and difficulties they may encounter. We also summarize ways that the MBMD can be used to recommend interventions before and after surgical and non-surgical approaches to pain management. This information is important for exemplifying the role of the psychologist in a wide range of pain treatment settings. I probably don't have to tell you that pain is one of the most prevalent health issues in North America. Approximately 100 million Americans suffer from chronic pain, and 1 in 10 has experienced pain every day for at least 3 months. Despite a panoply of interventions, some patients fail to achieve pain relief. For these, the chronic pain patients, a downward spiral of pain, disability, despair, healthcare utilization, and poor quality of life results. This can cause immense costs for both the individual and society. This, in fact, makes pain one of the most costliest health issues in North America. Many emotional and physical health consequences are also associated with pain, as you can see on this slide. Things like depression, sleep problems. Chronic pain is likely to be one of the most powerful detractors from the quality of life of humans worldwide. Getting into the pain experience a little bit. The pain experience involves far more than simple nociception or the biological process through which the stimulations of nerves send information to the brain about possible tissue damage. As we noted in our advertisement of this webinar, I'd like to reiterate what we said there. The patient's unique constellation of genetics and prior experiences, as well as their psychosocial assets and liabilities, things like their coping style and their mental health status. All of those things work together to form a cognitive and affective lens that affects how nerve stimulation is experienced, which in turn produces a biobehavioral response. In recognition of this complex interplay, a biopsychosocial model has come to be widely accepted in conceptualizing chronic pain over the past 10 years. With psychosocial factors now firmly a part of this integrated conception of chronic pain, mental health professionals such as yourselves have assumed an important role in pain assessment and treatment. Today's webinar will be focusing on a tool that is available for these professionals to use in a wide range of pain treatment settings, the MBMD, and its specialized pain report. The MBMD, originally published in 2001, measures a variety of psychosocial factors that are central to the experience of and response to pain. A few are listed here, including affect, things like anxiety and depression, personality and coping styles, and health-specific attitudes and behaviors. Other patient dimensions captured by the MBMD are also important to consider given their track record in predicting outcomes in various medical populations. For instance, as you see here on this table, empirical research has documented a number of patient factors that are associated with optimal as well as negative outcomes after things such as major surgery. These range from their attitudes and outlook to their coping style, and also their social support system, and of course, their outwardly observable health behaviors. Psychological distress states are generally also associated with negative outcomes. We will be exploring how the MBMD uses this and other information on patient characteristics to facilitate assessment and interventions in various pain treatment settings. A little bit of a background on the Millon test. The Millon research team has been developing comprehensive psychological tests for various populations for the past 5 decades. In work that was rooted initially in the science of personality theory, particularly the biosocial theory of Millon. This lab began developing personality tests for medical patients in the 1970s, an innovative notion in its time, and one that is more relevant than ever in this era of complex medical regimens and increasing role of patient behaviors that can determine successful outcomes, including in the context of pain treatment. The initial test born from this work was the Millon Behavioral Health Inventory, or MBHI, in 1981, which was shown over the next 20 years to be successful in predicting a wide range of medical phenomena, ranging from things like how long a patient waits before going to the hospital after heart attack symptoms occur. It also was associated with which patients would succeed with a home-based versus clinic-based dialysis, who survives best after a heart transplant and has the least complications. This is just a sample. During the 1990s, Millon's team began to work on a new version of this test, which would draw upon the discoveries in behavioral medicine research that had come about since the launching of the MBHI. This new test was named the Millon Behavioral Medicine Diagnostic, or MBMD, to stress the influence of this new vibrant field of behavioral medicine research, which is still a driving force in health-related research today. The MBMD was designed with a multidimensional model that integrated Millon's personality theory with revisions in DSM and with emerging basic and clinical research on the role of patients' attitudes, coping styles, and resources in determining health outcomes. To address the emerging medical populations of this era, the test was normed initially on a wide range of medical patients, including those with heart disease, cancers, HIV, neurological conditions, and other medical disorders. This research resulted in the launching of the MBMD as we entered the new millennium. The most recent research with the MBMD has led to the development of specialized test reports for pain patients. This involved collecting a large normative sample of pain patients across the U.S., establishing pain patient norms, conducting reliability and validity studies, and developing distinct narrative test reports for pre-surgical and non-surgical pain treatment venues. We will be summarizing this work in today's webinar, but you can also find a detailed description in the MBMD pain manual. The MBMD is considered a multidimensional broadband test, meaning that it strives to present a comprehensive multi-level picture of the patient in terms of factors that could determine the success of medical treatments. This is very different than a unidimensional test like a depression or anxiety inventory, given its scope. It's also quite different than a personality inventory designed for healthy populations or psychiatric populations, given its unique focus in normative development on medical patients. Within our model, which we use to determine the scope of the MBMD, there are several psychosocial characteristics, as noted in the orange boxes here, that can influence health maintenance and healthcare delivery and costs, noted in the blue boxes, which in turn all work together to determine health outcomes, the green box. These psychological characteristics can be grouped into the following 4 categories: psychiatric indications such as anxiety, depression, and other Axis 1 related disturbances; coping styles such as the behavioral, cognitive, and interpersonal strategies that patients use; stress moderators which comprise appraisals, resources, and contextual factors. And finally, negative health habits, which can compromise medical treatment. Health maintenance, the first of the blue boxes, includes patient behaviors that can contribute to disease risk or health preservation, their attitudes toward diagnostic testing, and their emotional reaction to initial diagnosis. Healthcare delivery processes, the things that happen after a diagnosis, refer to reactions to medical procedures, medication management, patient-physician communication, health utilization behavior, adherence to medical regimens, and finally the need for intervention to manage illness. All of these processes lead to health outcomes, hence they're important for the MBMD coverage. The logic behind the 7 MBMD domains that are the backbone of the test report is used to organize the profile and the narrative report. The first 2 domains, response patterns and negative health habits along the top here, assess response patterns which capture how the patient communicates about health issues and how they approach the taking of the test. Problematic lifestyle behaviors include things that could compromise medical treatment and require attention by the clinician. The next 4 MBMD domains assess psychiatric or psychosocial variables that may shape the way patients deal with health problems and identify attitudes that may exacerbate their ailments and interfere with overall prognosis. They are the psychiatric indications, coping styles, stress moderators, and treatment prognostics. The final domain noted here is a synthesis of all this information into what are called management guides. These facilitate triaging and decisions about the ways to optimize medical outcomes by addressing patient liabilities and intervening via counseling or cognitive behavioral skills training. Let's walk through some of the details of each of these areas. The validity indicator and response patterns speak to how the patient responded to the test items and also their style of relating. The validity scale will tell you if you have a valid test or not. A score of 0 is a valid test. A score of 1 or 2 may indicate inadequate reading skills, confusion, or random responding, and call into question the validity of the test. The disclosure scale measures the degree to which patient was open, honest, and self-revealing when responding. Desirability taps the degree to which test results may have been affected by the patient's inclination to appear socially attractive, morally virtuous, or emotionally well-composed. Finally, the debasement scale assesses the patient's inclination to deprecate or devalue him or herself by presenting more troublesome emotional and personal problems than are likely to be uncovered upon objective review. So these scales tell us not only about the patient's test-taking behaviors, but also give us a window into how they might communicate with healthcare providers about their medical status. Thus, they can help the provider better understand their patients and speak their language, if you will, in ways that could optimize communication and patient-provider relations. The negative health habit scale assess troublesome lifestyle behaviors that may exacerbate medical problems or undermine treatment efforts. The next section, the psychiatric indication scale, assess psychological problems that may place a patient at a disadvantage by complicating or undermining surgical or medical treatment efforts. These are among the types of psychiatric and neurocognitive factors shown to contribute to the exacerbation of many medical conditions and to the relative success of procedures ranging from surgery to dialysis. These factors may also contribute to how patients communicate their symptoms, react to major medical procedures, and manage their medications and post-treatment lifestyle changes. The 11 MBMD coping style scales are listed here and reflect aspects of Millon's personality theory that can contribute in important ways to a patient's ability to adjust and adapt to their medical condition. The coping style scales reflect the cognitive, behavioral, and interpersonal strategies patients use to acquire rewards and to avoid discomfort in their lives. These styles are derived from Millon's personality theory and are described specifically in the MBMD as they relate to the patient's transactions with healthcare personnel. The scales correspond, as you can see, to Axis 2 personality disorders, including those that have been added most recently to Millon's classification system. In naming the MBMD scales, we used adjectives that reflect how the patient is likely to come across to healthcare providers, stressing the interpersonal qualities. As such, the names of the 11 style scales are things like introversive, inhibited, dejected, cooperative, sociable, and so on. It should be noted that although these scales are designed to assess characteristics that qualitatively resemble DSM-Axis 2 personality disorders, the scores that reach the cutoff for presence or prominence on these scales are more likely to quantitatively reflect a normal coping style that is not in the range of an overt personality disorder. As an example of how Millon's personality theory can be used to understand these different coping styles, we focus on 4 very different coping styles highlighted here: cooperative, sociable, confident, and oppositional. According to the theory, one can classify personality tendencies on the basis of at least 2 major axes: the self-other axis and the passive-active axis. Self-other refers to a focus on the self versus others, for gathering reinforcement, or for protecting oneself from life and threat and pain. The passive-active axis refers to the tendency to be a passive recipient versus an active seeker of reinforcers or protection. We think of personality types and coping styles as some combination of these axes. For instance, the dependent styles, which are low in self and high in other focus, can appear in a passive form, where patients might appear cooperative, reclining, accommodating, or an active form, where they might be sociable, outward, dramatic, or flighty. The independent styles, which are high in self and low in other focus, may come in the passive form, patients appearing confident, self-assured, and entitled, or an active form, where a patient may appear oppositional, imposing, controlling, dissatisfied, or unmanageable. Now, applying these traits to healthcare settings, patients who score high on the cooperative scale tend to be eager to attach themselves to supportive healthcare professionals and will follow medical advice closely. However, these patients usually do not take the initiative to seek treatment and will need to be told exactly what to do. On the other hand, they are pleasant, overtly cooperative, and accommodating. High scorers on the sociable scale, on the other hand, tend to be outgoing, talkative, and charming. However, they may be changeable in their likes and dislikes. They're usually very cooperative when following a treatment plan initially, but this may be short-lived. They are concerned with appearing nice and attractive, and they may be disinclined to face their problems. Ensuring that they take their medication and follow their regimens may call for persistence from the healthcare personnel. High scorers on the confidence scale are self-assured and confident. However, they're easily upset by physical ailments and will be motivated to follow treatment regimens that they believe will ensure their well-being. They may expect to be given special treatment, in fact, by healthcare personnel and will tend to take advantage of opportunities that may improve their condition. It is important to them that they be treated in a courteous and professional manner, and if they're convinced of the importance of following a regimen, they will do so earnestly. Finally, high scores on the oppositional scale are unpredictable and difficult. They may be erratic in following the treatment plan, over-medicating or under-medicating without consulting their physician. They often seem dissatisfied with the physical and psychological state and sometimes dissatisfied with their treatment, of which they will complain. They may often express regret and contrition after they make those complaints. So they have a tendency toward mood swings, and rapport may be very difficult to establish and maintain. Moving to the stress moderator scale, these are factors that may modulate how patients respond to the challenges of life, stress, and illness. Think of a sound amplifier. These factors can turn up or turn down the apparent volume of stressors. In doing so, they can dampen or amplify the impact of stressors on their lives. Some can act as natural insulators or buffers, things like social support and spirituality, and the healthcare provider may want to enlist these characteristics. Some, however, are obstacles that can be modified through techniques such as CBT, things like illness apprehension, pessimistic thoughts, and pain sensitivity. The treatment prognostic section is the next section, and it asks, how is this patient likely to respond to things like a life-threatening diagnosis? How much information can they assimilate? How might they respond to physical demands of major treatments ranging from general anesthesia to surgery to chemotherapy, radiation, or transplant? How will they be during the early recovery in the hospital setting? And finally, after they're released, can they handle the demands of a post-treatment self-care regimen and medications in particular? So the treatment prognostic domain seeks to predict patient treatment-related outcomes. The treatment prognostic domains also address the likelihood of healthcare activities such as overutilization and medical noncompliance. These activities are associated with a long-term cost of care and are thus important to be able to predict. I should note that since these predictions require ultimately tests of predictive validity to anchor them, only the coming years of research will bear out the true value of these scales. Finally, the management guide section of the test amalgamates many test scale values to synthesize judgments on, first, the likelihood of a problematic treatment course, and secondly, the appropriateness of psychosocial intervention. Now, having presented an overview of the basic components of the MBMD, we now move to a description of how the test has been specifically geared toward the pain setting. The MBMD chronic pain norms are based on a sample of 1,200 chronic pain patients drawn from 7 user sites across the country. The sites were diverse, representing a variety of settings in which pain patients are commonly evaluated. Nearly all the patients for the validation study were recruited between 2006 and 2009. Approximately 70% were white, with African Americans and Hispanics slightly over 10% each in the sample. Finally, about 61% of the total sample had a high school education or less, with only about 15% having earned at least a 4-year college degree. The patients in the norm sample can be further differentiated according to whether they were being evaluated for a surgical treatment, such as spine surgery, surgical implantation of a spinal cord stimulator or intrathecal infusion pump, or whether they were being treated with a non-surgical approach, such as a multidisciplinary treatment program or a non-surgical medication treatment. Each of the sites furnished an estimate of the types of evaluations they conducted there, and the breakdown was approximately 37% were for pre-surgical evaluations and 63% for non-surgical evaluations. In terms of the data that emerged from the normative studies, tests of reliability and validity were conducted. In terms of reliability, there was evidence for good stability over time for the scales of the test, as well as internal consistency with a median alpha of 0.75. Validity studies included studies that established the associations between the MBMD scales and widely used self-report measures. These showed strong evidence of convergent validity with things such as the MMPI and various pain assessments. We've summarized these in the appendix, so you can refer to those later. In terms of predictive validity, this was established by relating MBMD scale scores longitudinally to patient outcomes in a comprehensive pain treatment program, as noted in the next slide, which covers Study 4. The Study 4 overall showed that pre-treatment MBMD scores for all the major sections of the test were predictive of pain patient outcomes in a comprehensive pain treatment program. On the next slide, you can see a sample of some of that data where patients who were classified as having been a successful case based on the amount of pain reduction they experienced in the treatment program had substantially different baseline MBMD scale scores in several domains. This is simply raw scores on this table. The MBMD, based on the results of this research, has now been customized for pain patients and offers 3 distinct features from which users can choose: chronic pain norms, pre-surgical pain patient reports with interpretive information, and non-surgical pain patient reports with interpretive information. The narrative reports are based on a comprehensive review of the literature, input from experienced practitioners during development, and extensive reliability and validity data drawn from a national and diverse normative sample of pain patients, as I have just described. The chronic pain norms allow MBMD users to interpret a patient's scores in the context of a large sample of chronic pain patients. However, the user is cautioned against interpreting a pain patient's scores solely with reference to the chronic pain patient norms, as doing so has the potential to be misleading. We'll explain this in a few minutes. In this table, you can see the raw score means of the MBMD clinical scales are compared between the members of the chronic pain norm sample, 1,200 of them, with members of the MBMD general medical norm sample, which consists of 720 patients diagnosed with cancer, diabetes, neurological disorders, and other illnesses. Cohen's B, the statistic used here, is a commonly used measure of effect size that expresses the difference between the 2 means in standard deviation units. Using this metric, the largest of the mean differences are shown here, and they range from things that are greater than 1 standard deviation, such as the functional deficits and pain sensitivity scale, 3/4 of a standard deviation on scales such as illness apprehension, future pessimism, and adjustment difficulties, and about 1/2 standard deviation on things such as anxiety, depression, cognitive dysfunction, and psychological referral scales. All of these are sizable differences and are in the direction of higher scores for the chronic pain norm sample. So you should keep this in mind when you decide which sets of norms to use in interpreting the test results. Professionals who commonly evaluate pain patients are not surprised by the results presented here. It is important that the MBMD scores be interpreted with reference to both normative groups. Interpreting scores only for the pain patient sample, however, could result in serious errors in interpretation. So as these data show, a patient with scores on these scales that are in the average range for a chronic pain patient may be very far above average for medical patients in general. These are just some things to keep in mind as you use some of the test results. As can be seen in this slide, this is one patient with their scores translated to the 2 different norm groups, with the general medical patients on the left and the pain patient, chronic pain patient norms on the right. The overall profiles are similar, yet specific scales may or may not enter the range of prevalent concerns based on which normative group is utilized. Because many of the substantive score differences between chronic pain patients and general medical patients, we recommend that scores relative to the general medical norms constitute the primary basis for interpreting the scores of pain patients who take the MBMD. Moving on to the test reports themselves. The MBMD yields 2 distinct test reports based upon the nature of the pain patient population of interest: a pre-surgical report and a non-surgical report. You can see the components of those reports here. I'll start with the pre-surgical report. The pre-surgical report has information on the graphical profile, as well as narrative and tabular information on pre-surgical considerations and post-surgical considerations. This would be in addition, of course, to the MBMD sections on overall test interpretation and the health provider summary. Moving inside of that test, what comprises the pre-surgical and post-surgical sections of the test? Pre-surgical consideration sections has 6 components. The patient's communication style is the first, and this can aid the provider in their transactions with the patient. The next 2 sections identify major surgical outcome risks and secondary risks. The next section is a section that reports on patient assets as well as patient liabilities that could be involved in optimizing outcomes. The next section, which is titled Predicted Block Prognostic Category, this refers to a researcher named Block. In an influential 2003 book, Block and colleagues proposed an algorithm for combining information obtained during the pre-surgical evaluation of spine surgery candidates into a prediction about the patient's likelihood of experiencing a successful surgery. Block's system has had a strong influence on the practice of pre-surgical psychosocial evaluations, not only for spine surgery, but for surgical device implantation as well. A multivariate algorithm uses MBMD test information to place a patient into one of the 4 block classifications. Finally, a section concludes with a summary of recommended pre-surgical interventions to improve the odds of a successful surgical outcome. A pre-surgical test report will be demonstrated for a clinical case in the second part of this webinar. Moving to the other type of report, the user also has the option of obtaining an MBMD non-surgical report for patients who are being considered for pharmacologic or behavioral management. As can be seen here, this report comprises both pre-treatment and longer-term management components. The pre-treatment sections cover patient characteristics, patient-provider communications, predicted response to a non-surgical intervention based on those assets and liabilities that were predictive of pain program outcomes in our MBMD validation studies. The next section provides longer-term management information that provides theory-based predictions about the likelihood that comprehensive pain management will lead to improvements across various areas of functioning. I've included here a couple of samples from a test report, which are also available to the people who attended this webinar as a PDF that you could have downloaded. Some of these pre-treatment sections are illustrated here. Some of the longer-term management sections are on the next slide. I'm going to go into a little detail on these final sections. A long-term patient behavior section offers predictions based on the test profile that the patient will be more or less likely to engage in optimal post-treatment behaviors and experience good progress. The next section after this, not pictured here, will provide predictions about long-term gains and challenges likely to be experienced in areas such as long-term quality of life and psychosocial functioning. 2 final sections of this report focus on, first, psychosocial management needs. The MBMD scores are used as a basis for statements about the patient's apparent need or benefits to be derived from adjunctive psychosocial interventions, such as psychiatric treatment, emotional support group, or behavioral adherence management. The final section, medical healthcare delivery issues, this section uses an algorithm to integrate MBMD scale scores to make theory-based statements about the risk for 3 important healthcare delivery issues: doctor dependency or self-care problems, misuse of opioid medications, and long-term disability. For instance, increased risk for opioid medication problems is determined from an algorithm that blends information on the alcohol, drug, cognitive dysfunction, emotional lability, non-conforming style, and medication abuse scale. Having gone through a description of all these scales, what are some of the ways that this information from multiple sections of the test can be put together in an evaluation? What do I have to know about the ways that the individual test scale scores are calculated? What do the numbers mean? Well, without going into a lot of detail, there are metrics that are used in the MBMD that are unique. Professionals who've been using the test for either pain patients or other populations have grown accustomed to the use of prevalence score metrics. Prevalence scores take into account estimates of the prevalence of each characteristic measured by the test as observed by clinicians. And you can find more detail about those calculations in the MBMD manual. As previously noted, prevalence scores based on the general medical norms should continue to constitute the primary basis for interpreting pain patient scores on the MBMD. Now, because the MBMD scales represent traits and behaviors along a continuum, one can actually interpret both low and high prevalence scores as follows. A prevalence score below 35 constitutes a potential asset. A prevalence score 75 to 84 is associated with a moderate or present liability, and scores above 85 are generally associated with a marked or prominent liability. To supplement the prevalence scores as a secondary source of interpretation, normative scores relative to the chronic pain sample are offered in the form of percentile scores. Percentile scores were chosen because their interpretation is simple and straightforward. Cutoffs are not suggested for the chronic pain percentile scores because, again, prevalence scores based on the general medical norms should continue to be the primary basis for interpretation and decision-making. I will end by going through the major sections of the assessment activities that could involve the MBMD. These are several steps that should be followed when interpreting the test scores. First, the clinician should review various sources of information ranging from the medical condition and clinical observations to other formal assessment instruments, and finally, the patient's background and demographics, things like age, race, ethnicity. Next, the overall validity of the test should be noted, and we've talked about that already using the validity scale. Again, a test with a score of a 2 is likely invalid. A test of a score of 0 is valid. The 3 response patterns are interpreted next for disclosure, desirability, and debasement. And these are classified as an unlikely problem area, possible problem area, or likely problem area. Under certain conditions, adjustments have been made to the prevalence scores of other scales based on the to correct for response distortions that are evident in these scales. Next, one would move to the psychiatric indications, coping styles, stress moderators, and treatment prognostics domain. The domain profile analysis begins with a review of the elevations greater than or equal to a prevalence score of 75 on psychiatric indications. Next, the configuration of coping styles should be reviewed. Often there are 2 or 3 elevated coping styles in a specific pattern. So the configuration of these is important to interpret. This is followed by interpreting elevations on stress moderators and their configuration. The treatment prognostic section is the next to be analyzed, with the individual elevations on these scales viewed as separate indices. Fourth, one would integrate the information in the profile of the MBMD scales and draw conclusions relevant to the management guides, which give information on adjustment difficulties and the need for psychological referral. Finally, any noteworthy responses should be considered, and the healthcare provider summary can be considered as a practical summary of the assessment, which can be placed in the patient's chart. At this point, I'd like to turn over the presentation to my colleague who will present on a case study.
Thank you so much, Dr. Antoni. This is Anne-Marie Kimball. I am going to cover, as Dr. Antoni mentioned, a pre-surgical report and give you some of the highlights from this report. The pre-surgical report, remember, covers or includes sections on patient-provider communications, major surgical risks, secondary surgical risks, patient assets, the block categorization, and pre-surgical and post-surgical considerations. So we're going to start with the demographic page, which of course just shows you some basic information about the patient. This particular patient is a 35-year-old white male. He's divorced. He's a high school graduate, and he came in because of pain. That is a major problem for which he'd been seeking medical help. He was given the MBMD, of course, as part of a broader evaluation, and these are the results of the MBMD. So his responses suggest an effort to present a socially acceptable image and resistance to admitting personal problems. You can see first, I'm sorry, I should have pointed this out, that this is definitely considered a valid report with a score of 0, as Dr. Antoni mentioned. So the interpretive report, because it is valid, we'll move forward. It may not include certain features of his emotional vulnerability, however, because of the patient's noted resistance to admitting personal problems. He's probably experiencing problems also with maintaining a regular exercise problem and maybe experiencing problems with overeating, as you see. So looking first at the current psychiatric symptoms or disorders, you'll note that this is, again, interpreted looking at the general medical norms. These are the psychiatric symptoms or disorders that should be the focus of clinical attention. They're symptoms or disorders that may affect his responses to healthcare treatment and his ability to adjust to or recover from his medical condition. So this patient reports relatively high levels of anxiety and depression. These elevations are probably due to the recent medical diagnosis or the upcoming medical procedure for which he's seeking evaluation, and they are probably temporary. Characteristically, this patient is agreeable, confident, he's adaptive to changing circumstances, but his concerns about his illness may be too serious to dismiss, and they may result in some debilitating anxiety complicated by an uncharacteristic depression for him. So the healthcare team here should really encourage and reinforce this patient's sense of control over his illness, and then that, as a result, he would likely take adaptive measures to reduce the distress he's experiencing. This report also indicates that some short-term pharmacological agents may also be beneficial. So as for coping styles, looking just at the lower part of this table, although this patient seems to need frequent social activity and stimulation, he is, as I mentioned, characteristically self-confident and easygoing in relationships with others. He's usually able to cope with minor stresses and discomfort, but he is likely to find this kind of chronic illness or pain problematic. So the constraints of a long-term illness may lead to increasing irritability and dramatization of his discomfort, and he may, when possible, seek out pleasure and indulge his desires beyond the ordinary. He may fail to be adequately attentive to matters of a repetitive nature, particularly things that are unappealing, like adhering to a long-term treatment regimen. His self-assurance is likely to be reflected in a disinclination to take the early stages of an illness or treatment seriously. He's likely to deny the potential severity of physical symptoms or maybe overlook them until they're too troubling to be ignored. He does not tolerate frustration well, and he probably won't like being a patient. He may exhibit both annoyance and flippancy in an effort to cover up the anxiety he feels beneath that kind of surface calm. And pressure to face up to the reality of a serious illness or a necessary course of extensive treatment may really result in irritability, withdrawal, or active uncooperativeness on his part. Even when he's making a genuine effort to be cooperative, he'll probably be impatient with rules and expectations around this treatment. He may just consider self-discipline and punctuality and record-keeping as things that are boring and burdensome. For the most part, healthcare personnel should be really comfortable, though, interviewing and dealing with this patient. If anything, care should be taken not to be seduced by his easy rapport and his apparent cooperativeness. If he seems indifferent to his illness, maybe seeming too relaxed and self-assured, it may be necessary to be firm about adherence to a treatment regimen, and if appropriate, really convincing warnings and clear instructions should be spelled out and followed up with regular checkups. The next slide shows that same table of psychiatric indications and coping styles, but reflected with the chronic pain norms, which, as you remember, Dr. Antoni just told you, are measured in percentile or provided in percentile scores rather than in prevalence scores. So this provides that comparative information regarding the patient's similarity to other pain patients, but remember the pain patient summary and the interpretive report are based on the general medical norms. But the chronic pain norms allow MBMD users to interpret the patient scores also in the context of the large sample of chronic pain patients, but as Dr. Antoni pointed out, the users cautioned against interpreting the pain patient scores solely with reference to chronic pain patients because that can be misleading. You can see here that there's few large differences, but again, if you were looking at the report, you would be able to compare these side by side with the chronic pain norms. With the general medical norms. So this next section is the stress moderators. Again, back looking at the table expressed in general medical norms. This section notes the patient's personal and social assets and liabilities and how they may affect his ability to manage the stressors and burdens of his medical condition and his treatment. We would consider as liabilities his illness apprehension, functional deficits, pain sensitivity, and future pessimism. We would consider as assets his social support and spiritual faith. So this individual is extremely sensitive to physical changes, and that can result in many hypochondriacal complaints on his part, but because of his upbeat outlook, he is more likely to have the stamina to deal with his illness. But he would appreciate the ability of his healthcare team to deal with his current healthcare needs and avoid speculations about future changes. He may report significant decrements in his ability to return to his premorbid activities of daily living, either by denying concern nor being overly apprehensive. He's likely to maintain a reasonable attitude toward the obstacles that his illness presents. He reports a high level of pain sensitivity. He may become pessimistic about his future if his medical condition worsens or if he experiences unanticipated physical limitations. He finds the attention and concern of friends or family sufficient but not overwhelming. He has a great deal of confidence that his support network will be available in times of need. He believes that his future health may be determined in large part by his continual belief in spiritual or religious matters, and if he needs to deal with a chronic, complicated, or progressive illness, he might do better than most others owing to this strong personal and spiritual resource. So looking at those same stress moderators again in comparison to the pain patient norms, the scores are those areas of concern or assets or liability here. You can see in comparison. Again, these are percentiles rather than prevalence-based scores. So the treatment prognostics and management guide section, this section forecasts the patient's response to the medical procedures and medication. It is based on the patient's psychological profile. Medication abuse would be considered a liability for this patient, and his information receptivity would be considered an asset. So his ability to maintain his prescribed medication regimen may be compromised by his psychological profile. More specifically, his ongoing problems with his anxiety, the excessive worrying that may really affect him to such a degree that he may have trouble attending to the details of, for example, a medication schedule. So in some cases, his fears may be based on an expectation that such medications could affect his judgment and awareness level, and so the healthcare team should be alert to this and be prepared to address his anxiety symptoms. In terms of assets, he is open to receiving information or discussing matters pertaining to his illness, and this may help facilitate his adjustment to treatment and may be used by the healthcare team to improve health outcomes. So the recommendations for the general management of this patient would be the next section on the report, and this patient is likely to have a much slower recovery and may generate many more expenditures during the course of his treatment than other medical patients. And these complications and or expenditures will likely be affected by the liabilities and assets that we've just discussed. So kind of in summary, this patient may benefit from pharmacologic or psychosocial interventions, as you can see, and to address psychological issues that could affect his adjustment to his illness or his recovery following major procedures such as surgery. His tendency to become tense and anxious before or after medical procedures may really cause him to have trouble managing his own arousal level, and his psychological profile suggests that he might be a good candidate for supportive psychosocial group interventions or individual counseling to ameliorate these mental health problems. These interventions may be a cost-effective way to optimize his quality of life and minimize the post-treatment adjustment and recovery period. So again, looking at that same section, the treatment prognostics and management guides against the chronic pain norms. Similar pattern, but of course different scores because they're percentiles rather than prevalence. Again, though, you still see that the medication abuse score is a problematic area. And then research has indicated a number of consensual risk factors for poor outcome of spine surgery or device implementation, a number of which are measured by MBMD scales. And this particular patient's MBMD predicted level or risk for each factor is shown here. So you can note that his anticipatory anxiety, his pain sensitivity, and his catastrophizing are all risk factors that are considered marked risks. You see medication abuse, moderate, depression, moderate, cognitive deficits, lack of social support, and problematic compliance are all three low. And then the presurgical, the presurgical sections of the report end with recommendations for presurgical interventions if needed, and then moves to the post-surgical considerations. In the last two sections of the test report, then the MBMD makes predictions about outcomes after surgery and over the longer term in terms of patient behaviors, patient gains, and patient challenges. A number of psychosocial interventions designed to improve the chances of a favorable surgery outcome are described in the literature, and the patient's MBMD scores, suggest that the following interventions may be considered, and you can see those here: psychiatric consultation, stress management training, pain coping skills training, and a peer social support group are all advisable. And cognitive behavioral counseling, medication and or substance use counseling, and compliance monitoring are all suggested as areas of, or suggested as helpful. And then looking at the post-surgical patient behavior section, there is a high likelihood that he will change unhealthy body mechanics and complete a follow-up behavioral management plan, and an average expectation that he will comply with the general medical regimen. But the likelihood that he will avoid stressful behavior, and show good judgment in an exercise program, and avoid long-term general health complications, and maintain and paced and progressive activity gains are all low. Those are all areas that would be classified as having a low likelihood. So in summary, this patient may benefit from pharmacologic or psychosocial intervention to address the psychological issues that could affect his adjustment to his illness or recovery following major procedures such as surgery. And I will now turn this back to Dr. McCoo to see if there are any questions waiting for Dr. Antoni. Thank you.
Thank you so much, Dr. Kimball and Dr. Antoni. I think, Dr. Antoni, that there were a few questions related to the normative group that we should use. So could you explain and elaborate as to which of the normative groups we should use, whether we want to use the general medical norms, the chronic pain norms, and if we should use both, what would be the explanation?
I think clinicians who see a wide variety of patients, where they are trying to interpret test information on, say, some chronic pain patients on one day, heart disease patients on another, HIV patients, it's probably better in those cases to use the general medical norms to be able to place the pain patients specifically on a continuum that they are used to working with, they are used to using in their own decision-making. A person who is a chronic pain practitioner solely and sees a wide number of chronic pain patients may actually be the one who benefits the most from having the percentile scores that are based on a chronic pain normative sample. So some of this has to do with the user. I always am a believer that the more information you have, the better. And if you can look at both types of translation or report at the same time, that is having the prevalence scores on one side and the percentile scores based on the chronic pain normative sample, doing that in parallel will probably give you the most powerful interpretation. But when you make decisions about the presence or prominence of specific features of MBMD scales, I do still believe the primary focus in terms of quantitating the person's score should be done on the basis of the general medical norms.
Okay, thank you. Another question about two questions that pick up on medication misuse, abuse. How robust are these questions?
Well, the questions pertain to personality factors that might be associated with impulse control, with decision making. The medication abuse questions in particular would have to do with whether a patient endorses true or false to items such as, do you use expired medications? Would you use your cousin's medications instead of your own? And would you make decisions on your own about just how much medication you need on a particular day? So I believe the questions are fairly robust in tapping into the patient behaviors that may well happen as they leave the clinic with their prescription. In terms of having an ultimate test of medication adherent behaviors, I think the test can alert the clinician to the need for a very specific medication adherence measure that could be used in parallel with the test. But the items that are embedded in the test, both in the personality items and the specific medication use in the treatment prognostic section, are fairly robust when used at the level of a broadband test.
Okay, thank you. And then another question about the report. Are the pre- and post-surgical tables included in both the general medical report and the pain reports, or are both sets of norms provided in each report, or the results based on both sets of norms?
Well, let me see if I can follow that. So for years, we had the MBMD with its various scales that I went over, and then we've developed the pain reports. You will still be able to get all the scales that comprise the MBMD section. In addition to that, if you choose a pre-surgical report, you will get information on all of the MBMD scales in a tabular form or a graphical form with the pain patient norms used to generate the numbers and the general medical population used to generate the numbers. That will happen whether you choose a pre-surgical pain report or a non-surgical pain report. I hope that addresses that question.
Yes, and I would like to add to that, as part of the handout, we actually sent you a sample of both a pre-surgical report and a non-surgical report. And if you look at those reports, you'll see that you'll have information using both sets of norms. There are a few questions that I think we're going to we'll respond to you individually via email. But just to wrap things up, we provided a set of references for you toward the end of the handout. And also we want to let you know about training opportunities. If you'd like more in-depth training on the MBMD, you can earn up to 3 APA CE credits, and the link to access the training is here. If you have any other questions, certainly you can go to pearsonclinical.com/MBMD. And as Dr. Antoni mentioned, we included for you toward the end of the handout those validation studies 1 through 3. We'd like to thank you for joining us today for this webinar. We look forward to having you join us on some of our other webinars in the future. We'd like to thank Dr. Antoni and Dr. Kimball for presenting, and we hope everybody enjoys the rest of